Welcome, everyone, and thank you so much for joining us today and for being part of this timely conversation on COVID-19, gender-based violence, and health equity. Carlin, can you hear me? Just making sure. Okay, great. My name is Erin Wolfson. I'm the Community Engagement Specialist with the College of Medicine in the Division of Social Accountability and the College of Medicine at the University of Saskatchewan, I meant to say. This webinar is part of a series of online community conversations hosted by the Division of Social Accountability, featuring local thought leaders and experts, researchers and practitioners, and community and campus partners. As the pandemic unfolds, we aim to share knowledge, insights, and perspectives on emerging and pressing health equity issues, to share experiences, questions, and bold ideas for how to prepare for and address the impacts of the COVID-19 pandemic and beyond. So over time, we hope that in convening these conversations, we're able to increase awareness and understanding of why bringing health equity lens to our responses for COVID-19 matters, what it looks like, and how to take action. The COVID-19 crisis has amplified deep inequities in our society. And at the same time, we acknowledge and lift up stories of resilience and community. In Saskatoon and across the Saskatchewan, we know that agencies and communities are coming together across systems and sectors to raise questions and coordinate actions while centering the needs and lived experience of people living in vulnerable circumstances. We hope to highlight equity-informed responses and stories of local actions through these conversations so that we can learn from each other and fill in each other's gaps to support populations most at risk due to circumstances far beyond their control. So now is the time to channel this energy to enact long-term systemic change. So let us build links between leaders and efforts and share insights and learnings about what is possible. What is COVID-19 teaching us that might help us to advance health equity in our province? Before we begin, I'd just like to acknowledge the land we are on. I live and work here on Treaty 6 territory in the homeland of the Métis, and we acknowledge Saskatchewan as the traditional territory of the First Nations and Métis people, which includes Treaties 2, 4, 5, 6, 8, and 10. We pay our respects to the First Nations and Métis ancestors of this place, and we reaffirm our relationship with one another. We recognize the legacies of colonialism and systemic racism in Saskatchewan, which requires focus and sustained societal efforts as we confront historical and contemporary injustices and achieve health equity for all. Before I introduce our featured guests and host for this conversation, I'd just like to quickly introduce two of my colleagues from the DSA who will be helping to keep this conversation running smoothly. Joanna Winnichuk is here behind the scenes, helping to make sure the webinar is running smoothly. And Carlin Sagan will be moderating the conversation from the chat, watching for comments and questions and key themes. I'll hand it over to you, Carlin, to mention a little bit more about that.
Sure. Hi, all. My name is Carlin Sagan, the Global Health Manager at the College of Medicine, and I will be keeping an eye on the chat function to the right. So we generally won't be taking questions during because our participants attending don't have access. So please keep your comments going and your questions on the side, and I'll try to do my best to moderate a full discussion at the end. And as well, if you feel like introducing yourself and letting us know where you are and maybe what organization you're affiliated with, we'd love to see some introductions, and maybe you'll see some opportunities to coordinate with other people in the chat. So please do introduce yourself. And again, if you have any questions, you can message me directly, but otherwise I will be diligently taking notes and hope to hopefully have a really great discussion afterwards. So thank you so much. Glad to see you all here.
All right, wonderful. All right, well, this week we're so pleased to welcome Joanne Dusel and Karen Wood to lead us in this really timely and critical conversation, responding to the needs of individuals experiencing intimate partner violence in the context of a pandemic. And just to stop to say thank you so much for introducing yourselves, everybody. Joanne is I'm just going to introduce you briefly. Joanne is the Executive Director of the Provincial Association of Transition Houses and Services of Saskatchewan, PATS. She is a longtime social justice advocate who spent 2 decades working frontline with women survivors of intimate partner violence at Moose Jaw Transition House. She's the co-chair of the Board of Directors for Women's Shelters Canada. Joanne strives to address the issues of IPV through public education, advocacy, and collaboration with community partners and government. Dr. Karen Wood is the Resolve Saskatchewan Academic Director at the University of Saskatchewan and adjunct professor in the Department of Sociology with experience teaching in sociology, social work, public health, and women's and gender studies. Karen comes to us with close to 40 years of experience as a researcher and practitioner in the areas of intimate partner, child sexual abuse, and family violence, both academic and nonprofit settings. Thank you so much, both of you, for being here today and to lead us in this important conversation. Over to you.
Thank you, Erin. And it really is a pleasure to be here. Joanne and I have worked together for quite some time, and we are hoping that this becomes more of a conversation. But we put together some slides and thinking that would provide just the background information for the conversation, and there is a lot of information, so it'll probably be 30 to 45 minutes or so with our slides talking back and forth. We do see that there are some questions submitted in advance, and so we'll try and integrate our responses to the ones that we can as we go, because we have integrated answers to those in our talk. And it's a pleasure to be here. So like Erin said, my name is Karen Wood, and I'm the Director for Resolve Saskatchewan. Resolve is a tri-provincial research network, Alberta, Saskatchewan, and Manitoba, led out of Manitoba, funded through the Prairie Action Foundation. And we work collaboratively with partners in the community in addressing gender-based violence. Joanne?
Okay, well, yes, I'm Joanne Dusel. I'm the Executive Director of PATHS. We are the member association for women's shelters and family violence counseling services across the province. We have 24 member agencies currently. And yeah, I'm just really happy to be here today and happy that so many of you are able to join us.
Yeah, thank you. And I do, Erin, thank you. I appreciate the treaty acknowledgement. I see that there are people from across Canada, and so just want to really make a point of remembering for myself as we engage in our learning opportunities regionally and nationally that we're all treaty people, and our efforts towards reconciliation and recognition are critical to addressing these and all kinds of other hurts that have and continue to occur in our communities. So today our talk, we'll be linking research and practice with some of the challenges related to the pandemic, and by providing an overview of gender-based violence and a particular focus on interpersonal violence as a health equity issue. Joanne, can you see the...
I did manage, I can see you. So.
Okay. So we'll be doing this throughout, folks. Yeah, is that right?
So you're good with the slide that you can see?
Yes, thank you.
Okay.
So a little bit first, just as an introduction, what is gender-based violence? It's violence that is committed against someone based on their gender identity, gender expression, or perceived gender. And I won't get into a conversation about what that means, but that is a broad area of understanding in and of itself. The most important point is that gender-based violence is about gender. It's violence directed at a person because of their gender. So when we're talking about health equity, what's really important here is that sex and gender matter. Both women and men experience gender-based violence, and we have done research through Resolve on men who experience intimate partner violence. That is a critical issue that needs to be addressed. The distinction here is that the majority of victims when it comes to gender-based violence are women and girls. And what's significant is that women and girls experience the violence because of their gender. They self-identify and or identified or presented or perceived as female. Gender-based violence is deeply rooted in gender inequality, and it continues to be one of the most notable human rights violations within all societies. It was noted in the 2019-2020 Department for Women and Gender Equity, previously known as Status of Women Canada, departmental plan that gender-based violence remains one of the most serious and pervasive human rights issues in Canada and in the world. In Canada, gender-based violence disproportionately impacts women and girls, as well as, and this is where the intersectionality piece comes in, and we won't be focusing on it other than how it relates directly to this talk. But other diverse populations are also vulnerable to gender-based violence disproportionately. That's including Indigenous peoples, LGBTQ two-spirit plus and or gender non-binary individuals, people living in northern, rural, remote communities, people living with disabilities, immigrant newcomer folk, children and youth, and seniors. All are at significantly higher risk of gender-based violence. And in terms of gender-based violence, there's broad consensus that unequal gender relations and patriarchal norms contribute to violence against women and children and have the potential, particularly during a time like a pandemic, have the potential to worsen and or possibly mitigate risk during times of crisis. In terms of the gendered impact of COVID-19 pandemic, I'm going to do broader strokes now, and then Joanne's going to speak more concretely about issues immediately related to intimate partner violence, and then we'll tie those into the more concrete issues related to the impact of COVID-19 pandemic related to the practicalities in intimate partner violence. So the gendered impact of the COVID-19 pandemic, we know that in times of economic instability, unrest, disaster, and that includes crisis like our current pandemic, they are linked to increased interpersonal violence, in particular violence against women and children. And we know that, and it's believed that the side effects of COVID-19 pandemic will continue to disproportionately impact women. And I'm drawing from an article recently published, Peterman and et al., which it's been a really good resource for a number of us across the country, who noted that over the past 50 years worldwide, there have been at least 10 different disease outbreaks, and that includes from Marburg in 1967 to Ebola in 1976, and then Middle East Respiratory Syndrome, or MERS, in 2012. And some, such as Ebola, they've resurfaced several times. The nature and the fear and uncertainty associated with pandemics like these provides an enabling environment that can and does exacerbate or spark diverse forms of violence. For example, the Ebola outbreak, there was an epidemic well documented of rape, sexual assault, and violence against women and girls in West Africa, directly linked to the Ebola outbreak. In terms of the COVID-19 pandemic, as of March 2020, there have been reports from Australia, Brazil, China, and the US, and now we have reports from other countries indicating an increase in violence against women and children. For example, Brazil has seen a rise of intimate partner violence by 40 to 50%. In Australia, they did a survey of 400 frontline workers who indicated that 40% of these workers indicated an increase in pleas for help, and 70% reported an increase in complexity of cases. In Italy, activists said calls to helplines had dropped, and that's an interesting dynamic we'll talk a bit about in a minute. But instead, the activists and workers were receiving desperate text messages and emails. And other countries expect to, and some have seen, an explosive increase in the number of reports of domestic abuse, and that's as the lockdown restrictions ease off. So there's a pattern that seems to be emerging of fewer contacts, less reaching out for support during lockdown, and then an explosion post-lockdown. And something that is relevant in terms of future concerns, it's predicted that zoonotic diseases, and 75% of emerging diseases are zoonotic, they originate in animals and transfer to people, they will continue to surface. And so the tactics and the issues we're facing now really that much more critical to respond to as there's a good chance we'll continue to need to address these up the road. So ready next, Joanne? So intimate partner violence, what is it? Do you want to take this away? Or
Sure. Yeah, no, I can. So For this talk, we are going to focus more in depth on intimate partner violence, which is one of the forms of gender-based violence. We do recognize that other forms of gender-based violence, like sexual assault, workplace harassment, etc., may also be increasing at this time. But for now, we are focusing in on intimate partner violence. Intimate partner violence is often more commonly known as domestic violence. And oftentimes when people think, what is domestic violence? The first thing that springs to their mind is physical abuse. So the punch in the face that leads to a black eye. I think that's what a lot of people think of when they think of domestic violence. And it's actually much more than that. Intimate partner violence is a pattern of behavior in which one partner exerts power and control over the other partner. In addition to the physical abuse that is sometimes, but not always present, there is likely to be psychological, emotional, verbal, financial, sexual, and spiritual abuse. So you will see things like one partner who doesn't want the other partner to work, partly because they don't want them to have contact with other people. That might be due to excessive jealousy, or it might be as part of economic abuse, a way to keep them dependent on the abusive partner financially. You see things, the types of control can lead to isolation, where the victim loses contact with family and friends, and before too long, they don't have a support system. They don't have someone that they can turn to explain what's going on for them and to reach out for help. Many times people think that all someone who is experiencing intimate partner violence has to do is leave, just leave the relationship. Why don't they leave? The problem is that the violence and abuse do not end when the couple separate. In fact, some forms of abuse, stalking behavior, harassment can actually begin or increase at the time of separation. And that's also the most dangerous time. That's when many domestic homicides have been shown to take place, at the time when the victim is considering leaving, or in the months shortly after leaving that relationship. So I'm just going to give you a few stats so you get a sense of the extent of intimate partner violence in Canada. So here's a couple stats from Statistics Canada's report, Family Violence in Canada. So in 2018, there were 93,000 police-reported victims or incidents of intimate partner violence. 79% of those were women. Now, it's important when you think of that number, 93,000, to look at the second point, which is just under 1 in 5 of those who are experiencing this form of violence actually report to police. There's been quite a few different studies on reporting levels, and actually 19% is the highest number I've ever seen for people who say they actually have reported their own victimization to police. So it's a very underreported crime, and that is due to the fact that there's still a lot of stigma around experiencing intimate partner violence. People still somehow feel that they are at fault and that they will be blamed for not leaving the situation sooner. In Saskatchewan, we have the dubious distinction of having the highest per capita rates of police-reported intimate partner violence among the Canadian provinces. So at 680 per 100,000, that's more than double the national average. In 1 year, police reported 6,170 incidents. So again, if you think that at most 1 in 5 individuals experiencing violence are actually reporting to police, think of what that number might actually be in terms of incidents actually taking place. And once again, we see that 80% of the victims were female. Sadly, on average, in Saskatchewan, a woman is killed by her current or intimate partner every 4 months. This diagram is here to give you a visual representation of where Saskatchewan fits with the rest of the Canadian provinces. And as you can see, it's not very good. We are far and away ahead of all the other provinces in terms of the per capita rates of police-reported intimate partner violence. I do want to make a note that if we were to show the territories on this map, the bar there would have to extend off the edge of your computer screen because the numbers there are exponentially higher. But we do have to ask ourselves, why is it that Saskatchewan consistently, over years, this particular slide is based on 2015 stats. The numbers go up and down a little bit every couple of years, but the ratios don't change. Saskatchewan continues for many years to hold this place as the highest rates among the Canadian provinces. There are numerous speculations about why there might be higher rates of intimate partner violence in Saskatchewan. But one thing I can tell you is that some of the provinces like Ontario, that has one of the lowest rates across Canada, have done a lot of work to intervene. They have been doing domestic violence death reviews since 2002. Every single domestic homicide there is reviewed, and recommendations are made to address why there were, when there were missed opportunities for interventions, and red flags, warning signs, systems failures, so that those things can be addressed. And what has happened in Ontario is that has led to legislation changes, such as the inclusion of domestic violence as a specific factor in occupational health and safety legislation, so that employers have a duty to keep their employees safe. And also public awareness campaigns, such as the Neighbors, Friends, and Family campaign, to help people recognize warning signs and how to help others safely, how to intervene if they know someone who's using violence in a relationship. And also the Make It Our Business program was developed in Ontario to help employers recognize and effectively respond when intimate partner violence is following the victim to the workplace. Across Canada, there are intimate partner homicides. In a 10-year period, there were 964. In just 1 year, 2017, there were 76 intimate partner homicides. And once again, you'll see 84% of the victims being women. I want to make a note here that sometimes when the victims are male, it's actually a male perpetrator as well. So you really need to delve into the statistics to really get at the genders of who is actually committing this violence. And again, very sadly, a woman in Canada is murdered by a current or former partner every 5.5 days. Mm-hmm. Since the lockdown, that ratio has increased. Overall, femicide being another form of gender-based violence in which intimate partner homicide is a piece, but there are other situations where women are killed because they are women. So that could be in the course of a sexual assault. It could be the murder of someone who's working in the sex trade, or other gender-based motives for that crime. So researchers have identified a couple of different models of intimate partner violence, and it is important to know the difference, just to be able to recognize them, because the responses to them can and should be different. One of the most common forms of intimate partner violence is situational couple violence. That's when conflict in a relationship, oftentimes it's younger people, they may not have good coping skills, there may be substance use involved, and an argument escalates and violence takes place. Some research suggests that both men and women are equally involved in this form of intimate partner violence, because men are likely to be larger, more powerful, stronger. Their violence is more likely to cause fear and to cause serious injury. This form of violence can be deadly, so it should not be dismissed. However, the next slide is going to talk about the type of violence that is actually more likely to result in death. So intimate terrorism is a very descriptive term for those relationships in which there is the pattern of violent coercive control. So very often the control factors are so strong, and threats and intimidation can actually be enough that physical violence may or may not even be part of this relationship. The tactics will vary from case to case. Often things like the not letting your partner work, not letting them stay in touch with family and friends, totally tearing down their self-esteem, making them think that they're crazy, that gaslighting that you hear about. So making them doubt their own senses and belief in reality is very often a piece of intimate terrorism. Intimidation often includes threats, both to the primary victim, to children, to pets. Sentimental property is often something that comes into it. Threats towards children in the sense of, if you ever leave me, you will never see your children again. Now, that could be interpreted in multiple ways. The whole goal here is to keep that partner in the relationship, keep them from leaving. And that is why when the time of separation has come around, if the abuser who is an intimate terrorist discovers that their partner is leaving and they're losing control, that can often be trigger for homicide. So this happens primarily in heterosexual relationships. The vast majority of time, 97% of cases of intimate terrorism, the perpetrator is male. And throughout our society, intimate terrorism is actually not as common as situational couple violence. But by the time someone who is experiencing violence comes to an agency like a shelter or a counseling service, what we find is in those areas, we see a lot of victims of intimate terrorism. So I think Karen already mentioned some of these categories of individuals who face increased risk. So I don't think I'll go over that again. We'll just go to the next slide. So we just wanted to let you know what some of the markers are for when a situation is very high risk. This is helpful for service providers. This is also helpful for people in the community. If you want to have a sense of when somebody that you know who is experiencing violence is in a more dangerous situation. So the factors on the next two slides here were developed as a result of the findings of domestic violence death reviews. So these are some, but not all, of the items that are very commonly in place in situations where a domestic homicide has happened. So again, that actual or pending separation is a key one. If there is a history of domestic violence, and it doesn't have to be in the current relationship, it could be in past relationships. If the level of violence within the relationship has been increasing, if the person is generally violent, is the abuser someone who gets into fights at the bar, has conflicts with coworkers, and just is violent outside of the family? When the perpetrator of abuse is showing obsessive behavior, so that's like checking up on their partner all the time. They need to talk about the situation all the time. They're perhaps very much, again, checking up all the time, that it fits in with the stalking behavior as an obsessive behavior. And when the perpetrator is depressed, and that could be either clinically depressed as diagnosed by a professional or just observations by family or friends. Prior threats or attempts of suicide are red flags. Any threat to kill the victim. Extreme jealousy is often present in the cases. And again, this very much fits into the gendered nature of this form of violence. When you think that if we go with sort of more traditional gender roles where the man was the head of the household and women and children were considered possessions, that is where jealousy fits in. If I can't keep my partner, if I can't control them, then I'm somehow less of a man, is the perception. And that is part of why this is so often present in these cases. You may be surprised to see the perpetrator being unemployed as a risk factor for domestic homicide. And yet, as I believe Karen is going to touch on later, economic stressors actually have been connected through research to a higher probability of domestic violence and domestic homicide. Substance use and abuse doesn't cause violence, but it can reduce impulse control and cause incidents to escalate to the point of serious harm or murder. Again, those attempts to isolate the victim are red flags. And when the victim has an intuitive sense of fear, This one is really important because research has consistently shown that when victims say that they are either concerned or certain that their partner will harm or kill them, that they are in fact in a very high risk situation. Also, research has shown that victims tend to minimize their risk. And so often they will say, no, I don't think my partner would ever take it that far. He loves me. I don't think he would kill me. Sometimes they're wrong. So when you do have a victim who has that intuitive sense of fear, take that very seriously. And of course, the more of these factors that are present, that indicates a more dangerous situation. The last thing I want to touch on here, and I think I'm turning it back to Karen after this, is strangulation. Just to note that this is a serious warning sign. It is connected to lethality. Oftentimes when women are strangled, and that means anything that cuts the airway off. So it's hands around the neck. It's like an arm pushing you up against the wall. It's like holding you down, maybe a weight on your chest or a pillow on your face. If you can't breathe, that has, again, linked to much higher rates. You see the percentage there of 750 times more likely. Individuals, perpetrators who strangle their partners have been linked by research to mass murder, as in the case in Nova Scotia, to later killing police officers. And sadly, again, strangulation is something that's witnessed by children. And when it is, then they begin to think that that is normal behavior. Also, I guess one final thing on this, when talking to those who are experiencing violence, sometimes the word strangulation doesn't resonate with them. So to use the word choking or, prevented you from breathing, just when you're asking someone if they've experienced this. Again, often women who are strangled show no physical signs, and yet there could be internal damage. So it's important for them to get medical attention in that situation. Oh, I do have one more. My apologies. Children who are exposed to domestic violence have lifelong impacts. They have psychological, emotional impacts. Their cognitive development is impaired. They have lifelong physical impacts, including things that you might understand like depression and anxiety, but also health outcomes with things like diabetes and obesity, things that you wouldn't necessarily think would be related to childhood exposure. An estimated 360,000 children are exposed to family violence or witness it each year. And unfortunately, again, sometimes this behavior becomes normalized. Children they learn what they live. So if they have grown up witnessing this type of behavior in their family of origin, they're not going to have good coping skills. They're not going to know other ways of acting. And also they're more likely to accept violence in their own relationship. Again, thinking that this is normal behavior. Support and intervention as early as possible can change the outcomes for these children.
And before I go on to the pathways, just one point to add, and Joanne and I were talking about this earlier, there's a strong body of research that shows that children who've been exposed to violence are impacted as if they were experiencing the violence themselves, even when they weren't witnessing, even in the same room. But to be in the environment where there is family or intimate partner violence, there's evidence, strong evidence to show that they are impacted as if they were the ones being harmed, which is quite extraordinary, I think. So now,
I just have one quick question. Sorry, Joanne, could you please close your chat function? It's creating a gray rectangle for the viewers.
Oh. I don't even see it, but I might have to escape here for a second. So I wasn't seeing the chat, but let's see, how can I close it? Is that better?
No, just on the far right side of the screen on the...
Oh, you know what? That's so that I can see Karen talking. If I close that, I don't see anybody and I feel like, how bad is it?
Could you move it just off to the side? It cuts off a little bit of the words.
Can I move this? Let's see. I don't know. I'll try. Let me see if I try speaker. Is that better?
That's quite a bit better. Thank you.
Okay, great. Thank you.
Thank you. Yeah, this technology, I'm actually appreciating that it works as well as it does, but I should touch wood to that. I just touched my hand because my last name is Wood, and that's what I do. So coming back to our slides, and back to linking the pandemics with the issue of violence against women. And we have, I recognize that some of my slides and Joanne's slides, violence against women and children, violence against women and girls, because they often, a lot of the research, in particular the Peterman research, they actually collapse violence against women and children because the issues that they relate are so complicated and implicated together. So pathways, the author Peterman and his research colleagues identified 9 pathways linking violence against women and pandemics. I'm only focusing on 6 because some of them are more related to global. They're important and they're relevant, but not as relevant to the discussion around our local regional focus today. So the first one is economic insecurity and or poverty related stress. That is clearly the result of pandemic planning and outcome. If a person is experiencing economic stress, experiencing poverty that they hadn't before, they experience fewer options, more limited access to health or to lawyers, to services. There's the stress, increased stress of possible food insecurity related to economic insecurity. And then aside from that and related is women's employment income generation. So if women are losing jobs, they have less access to independence and the stress related to economic insecurity. The second pathway, quarantines and socialization, the physical aspect itself, and all of these tie in together in different ways as well. But first, mental health is impacted. I suspect all of you have seen the evidence connecting mental health issues, increased rates of mental health issues related to COVID, and that is known to lead to increased risk of violence, as Joanne was speaking to earlier. And then quarantines and socialization also physically, just there's constant exposure to perpetrators on the part of somebody who is experiencing partner violence in their home space, and the inability of women to temporarily escape abusive partners. There's no getting away. There might be not a minute where they're not under surveillance. And there's also a sense of loss of control, for example, through quarantine. And so for an aggressor, that social isolation may exacerbate the stress. So like the structural and couple violence, as well as intimate terrorism, if a person is needing that control, it's exacerbated by that sense of loss of control due to quarantine. And then the third one, disaster and conflict related unrest and instability. There is not necessarily a full breakdown, but still impacted breakdown of social infrastructure. For example, access to health, limit your visits to the doctor, for example. Transportation, bus routes, bus systems. Here we can access buses, but it's been affected quite dramatically. Legal and security issues. So, for example, there has been some evidence that COVID is showing that men being charged and put in jail, numbers are down because of concerns of transmission of COVID within the jails. And so there's also, in terms of disaster and conflict related unrest, some forms of screening, detection, and or referrals might be lost. So women can't get out to see a professional who could then refer them or access another service. The fourth pathway, exposure to exploitive relationships due to changing demographics, really speaks to itself. A person might be vulnerable to control out of a need for survival, rent, food, childcare. And so maybe there's an expectation of quid pro quo. I know we heard about women who their landlord's expected sex in return for rent, that anecdotally. The fifth pathway, reduced health service availability and access to first responders. Like I said, health systems are often the first point of, they're impacted, and they are often the first point of contact for women seeking help. And in terms of identifying and screening. And so that is impacted through the pandemic. And any pandemic, of course, is an increased burden on health services and first responders. And so there's a limited capacity for further intervention in that way as well. And finally, the sixth pathway, virus-specific sources of violence. And, some of these are quite disturbing. And Joanne, we hadn't talked about this. I wonder if we should have given a bit of a risk of trigger warning, because we are going into some details. If anybody who's listening has experienced violence and abuse, just to make sure, that you have supports in place. And if not, we have some highlighted on the resource list to follow up if you need. And so, for example, an aggressor and abuser may use information or scare tactics to control or blame a partner, or they may withhold necessary safety items, the face mask, or even information to control in some way. And I would add, this wasn't added in the link, but to me it's a critical one, is technological challenges. So there may be a limited or even more restricted ability to reach out for support. A woman might be more susceptible to monitoring and or surveillance. If she could get a break and go to a coffee shop or goes to work or, drops a child off at childcare, there are a few minutes where she might be able to change a password. But when there's constant surveillance, there's no way she can change her password, so that she might be monitored. There might be tracking software, and I'm going to speak a bit more about that in a minute. I lost where I was. Oh, I see. Joanne didn't lose it. I did. There. IPV and COVID regionally. So I'm on to the next one.
Okay.
Thank you. And so regionally, and Joanne and I both can speak to this, occupancy rates in shelters in some cases have decreased. There may be a perception that shelters are closed or that they're not safe, and so that might impact women's sense of availability to use the service. Some services have reported higher calling levels and online searches for information. And social isolation, like I said, is a common tactic for abusers, and it limits the woman's ability to reach out for help. And so according to Statistics Canada, almost 1 in 5 Canadians are concerned about violence in the home during COVID-19. And this is, on to the next slide, from a recent Canadian Women's Foundation survey. Service providers that responded to this survey only expect community challenges to escalate. 85% of these responders, service providers, expect to see an increase in gender-based violence. 94% expect to see more mental health issues for women. 84% expect to see more economic insecurity, and 81% expect to see greater food insecurity for women. These service providers know sort of what's happening and have insight into what's, how things are unfolding. And so I think this is significant in terms of how things may happen over the next while. In this survey as well, the service providers highlighted additional barriers related to the pandemic. I don't know, Joanne, if you want to speak to this, or if you want to.
Oh, you go ahead.
Okay, so and Joanne and I both sort of overlap our research, and because Joanne works with the folks who are living this every day. There's an increased burden of childcare and education on women, and so that may be an added barrier to support and services. A loss of safe spaces for LGBTQ, Two-Spirit plus, non-binary individuals, and in particular for youth. So where is there a space for safety to be out that physical space where there's risk? They are even more restricted. and therefore at risk. Decreased access to community supports and services, which speaks for itself. And increased reliance on substances to cope with the added stresses. And as Joanne said, it's not necessarily causation. However, it's an inhibitor, and so escalating events. And increased reliance on substances to cope, lack of digital resources in the home to support work, education, and access to information about the pandemic. And that again seems to be critical these times of isolating practices like we're doing today. Technology is playing a big role in positively coping. But the actual technology, and if you go to the next slide, it leads to concerns related to technology. Because it's one of the tactics of control, and particularly the coercive control and hypervigilance that Joanne referred to earlier. There are ways that a person can track or monitor the activities of someone else by using different technology, and this is clearly easily exacerbated as a result of physical isolating practices, so like spyware. Technology safety projects can provide some women and girls experiencing technology-facilitated violence with enough information to strategically use technology in ways that can enhance their safety and take back some control. If they believe they're being stalked or monitored or abused through a perpetrator's misuse of technology, and in our resource list, we do have some toolkits that are available to look at what that means, because this risk is real, and folks might be reaching out to women to support them, not knowing that actually that might increase the risk, and we'll talk about that in a minute. Joanne, you want? So we're at 5. Yeah.
Yeah, I'll just speak to this one, and then we'll go back to you, Karen. So. Karen had mentioned that there may be a perception that women's shelters either aren't open or that they're not safe. And we just wanted to let you know that the domestic violence shelters in Saskatchewan are all open, and the domestic violence counseling services that are out there are adapting. So there may be more work being done through the use of technology, whether it be phone, chat, text, or online. Facebook, there's some closed Facebook groups. There's some people doing groups or counseling over video conferencing. The shelters themselves have taken all types of precautions to ensure that the shelters are a safe place for both clients and staff in terms of not being exposed to infection as much as they can. So they have enhanced cleaning protocols. They have reduced the numbers of individuals they would allow in the shelter to allow for appropriate social distancing. Some of the shelters have the ability to have isolation rooms where an individual or family could stay if they had been exposed or had symptoms of COVID-19. The staff would bring their food, bring them everything. They would have their own washroom so that they would be in a safe place, even in the circumstance that they might potentially have that infection. There have been arrangements made with alternative accommodations. In some cases, that's hotels. There's been a really great collaboration between government ministries in assisting the women's shelters in finding people safe places to be as early as possible when they are seeking help. So, for example, when a woman calls the shelter and she needs financial services, in normal times it could take weeks, sometimes several weeks to get that set up. But since the pandemic started, we've been able to fast track clients into income assistance, and also working with Sask Housing to fast track women and families into affordable housing units. So I know of one case here in Saskatchewan where a woman called, she had a family, she needed to be somewhere safe. She didn't actually even need to go to the shelter. The shelter staff were able to help her arrange everything. So she went directly from her home, which wasn't safe, to an affordable housing unit and had those income supports in place. So again, as circumstances change, the shelters have been responding, and we just really want to have that message out there that people should reach out for help. I think I will take this moment to echo what Karen just said also about if you are supporting someone or reaching out to someone who you feel may be at risk of intimate partner violence, be very careful how you do that. You don't want the partner to find out that they are having this discussion, because that can create additional risk for the victim. So as Karen said, there are some resources at the end that will help you reach out safely. And back to you, Karen.
Okay, so indicators of risk, and we're just leading into the last few slides and getting more into the pragmatics. This is for if you, just to be able to see if possibly someone you're worried about may or may not be vulnerable to abuse. If the person is being prevented from being safe during COVID-19, like if they're being prevented from social distancing or controlled to products the woman needs to be safe, is a partner monitoring where the woman goes inside and outside the home. And these are all coming out of, I think, the information Joanne and I provided earlier. Is she being restricted in who she sees, speaks to friends, family, supports, even going to the doctor? Is she limited in her access to information about COVID-19? Has there been an increase in emotional abuse or threats of violence, or have there been more episodes of violence in the home, the escalation Joanne talked about earlier? Is the partner displaying more controlling behavior or jealousy? Has she been strangled or choked? And one of the concerns is during COVID-19, a woman who might already be cautious about going for medical support if she's experiencing strangulation, maybe even more reluctant to seek medical attention, particularly given the concerns around either COVID transmission in the hospital or just overutilization of medical services. Is the partner pressuring or forcing her to have sex when she doesn't want to, or and this is critical as well, does the partner have access to weapons either inside the home or through family or friends? So the next slide, what to do. Do you want to take that away?
Sure. So as we said, victims, women's shelters, victim services, and anti-violence support workers are available. One of the most important things you can ever do for anyone that you think is experiencing violence is to let them know they're not alone. As simple, are you okay? Do you want to talk? Is there anything I can do? Those are very powerful questions to ask. Find ways to communicate with them securely. So if you do suspect that someone you know is experiencing abuse, something like a socially distant walk is the ideal way, because you're unlikely to be overheard in that context. Using something that's like a chat room where the text disappears is safer than using email or actual text messages. A phone conversation, if you're sure you're not going to be overheard, again, is safer than anything that will leave sort of a trail. I know Tracy from Stops to Violence is on this call today, and Stops and Saskatchewan SPCA and PATHS have jointly released an updated version of our Getting Out guide. And we had some really serious conversations around the risks of releasing this at this time where people are in isolation and possibly with an abuser, worried that if we put it on social media that people would be tagging their friends or like sending it to someone's inbox or something where a partner would get the sense that others are aware that the abuse is taking place. So just to be cautious about that. Always know that women are experts in their own lives. They need to be the ones to make the decisions about whether they stay, whether they leave. Sometimes it actually is literally safer to stay because, again, of the fact that the time of separation being the most dangerous time. If a woman is not in a position to make that move, please don't encourage them to do it before they are ready. Do help them to connect with support systems who can help them make safety plans for themselves and for their children. There are ways to make safety plans for children that are age appropriate, that don't involve actually naming, say, dad as a dangerous person, but really basic things like if you're ever scared where do you go? Who do you talk to? So that's a trusted neighbor, a family member, just so that there's a plan for children in place as well.
And to go on to intervention, what to do, Joanne and I were talking about, there are some very creative ways. I don't know if, I have to imagine that a number of you would have read the media attention paid to tactics in, I think it was Italy, there were a few other countries that were doing that, where the woman gave a signal to, there was a code word that she would give to a pharmacist, and the pharmacist had access to her personal information and would phone and get intervention right there while she was in the pharmacy. So there are certain strategies that folks can use that there may or may not be uptake on. I know of some women who've, I've heard about them maybe letting their neighbor know, if I move this curtain in this room to that position, that means please get someone to help me right away. Or Joanne and I were talking about is it the Canadian Women's Foundation signal?
Yes.
Yeah, right, where your thumb, fingers down. If you're talking to somebody, there's someone in the background, but they can't see you. And that might be a way of indicating that there's risk and please get help of some kind. So there are different strategies as well. And it would be, So one of the challenges is, how do we communicate those that doesn't then put a woman further at risk? So then broadening the focus towards prevention. All we've talked about is the person who is experiencing abuse. And we need to broaden this conversation, going back to gender-based analysis and gender-based violence more broadly and generally. Really critical that women are supported, that services are there. That's not what this is. What this is, say, it's a bigger picture. And for example, there may be things we can do in terms of prevention to support families and those who may be at risk of aggressing themselves, by supporting them to deal with stress more effectively, by teaching or being more engaged somehow, even with the isolating requirements, to give support in managing safely without the violence. So just wanted to make sure we go back up and have the bigger picture. And not positioning someone who's experienced a violation as the problem or a problem, because that's just perpetrating a structural system of positioning people in a way that's as a victim. And so finally, pandemic response. I think we're to our last slide. The issues we're facing call for all of us, researchers, practitioners, policymakers, to situate violence against women and children within the broader need for intersectional, gender and feminist-informed pandemic response. There's been some critique of the data and the research and the attention paid to the impacts of COVID-19 globally, and there's been very little attention paid to the gender-based impacts of that. And so a call for all of us to understand and take a look at that more fully, do the gender-based analysis. And to our last slide, those are our pops saying thank you. That's our reward, and your reward for getting through a long talk. We did have some questions, and I think Joanne and I touched on some of them that we received prior to. Erin or Carlin, how best to do this? Because I understand there are questions that have come up through the chat and question and answer section as well. Should we just run through the questions first, maybe?
Hi, I'm actually not sure. We are technically out of time and we've lost a few participants already. Might I suggest that we potentially pose these questions to you two to answer after the fact, and we can post as a follow-up to this discussion?
We could do that. We've answered most of them anyway.
You definitely have. Yeah, you definitely have. But we could maybe just follow up with you afterwards and post. So that said, if you do have any additional questions, those attendees, please pop them in the comments before you leave, and we'll try to follow up with Karen and Joanne after the talk concludes. So thank you very much for coming, and thank you both for speaking.
Yeah, thank you. That's great. Thank you so much. And if you're interested in learning more about upcoming health equity community conversations, you can head to our newly launched website. I've just posted the link in the chat for upcoming conversations, checking out our latest recordings, and you can also subscribe to our newsletter so that you can keep posted on upcoming conversations. Next week on Friday, June 5th, I believe, our conversation will be on harm reduction and COVID-19. And check out the Resource Hub for a growing list of critical health equity resources to support our local efforts. And if you have any great resources that you know that might benefit others, please do send them our way. There is more information on that website. So thank you so much again, Joanne and Karen, for joining us. And also please get in touch specifically on this topic if there's any other we certainly would love to continue the conversation moving forward. So thank you everyone for joining us.